Good afternoon, everyone. I'm Dr. Chandrikha Chandrasekharan. I'm a medical oncologist. I've been at the University of Iowa with the neuroendocrine program for almost 5 years now. And I hope for this to be an informal session. So I'm going to start with the list of questions that were asked. I'm going to start with some overview that I like to give patients about neuroendocrine tumors. So this is really just going over what we call in Iowa our toolbox. Since this session is focused on small bowel neuroendocrine tumors, I'm going to really start with the toolkit focusing on the small bowel neuroendocrine tumors. So small bowel neuroendocrine tumors usually refers to especially tumors that start in the jejunum or ileum or duodenum. Again, this is just the different parts of the small bowel that, is the long feet of colon, small intestine that you have. And most commonly, tumors start in the ileum, which is like the last part of the small bowel, but jejunal tumors or duodenal tumors are also described. Most often, the site of metastasis, meaning the site of spread, is a liver, but you can have spread in the lymph node in your belly cavity, also in what we call the peritoneum. A peritoneum may be a word that may not be, many of you may not be familiar with. Peritoneum describes to the space in your belly cavity. If you imagine all your bowel is wrapped by like a glistening cellophane sheet, and that can, it's there everywhere in your belly cavity, under your diaphragm, on top of your liver, on top of your small bowel, on top of your large colon. And so that's peritoneum, and tumors can also be on the surface of these, on this location. And then occasionally also we have involvement of the bone. So these are kind of the sites of spread of these small bowel neuroendocrine tumors. I've kind of put up the slide that kind of gives the list of toolbox or tools that you have for treating these tumors in general, like surgery, liver-directed treatments. Often the first step is octreotide or lanreotide. I'm calling it octreotide analogs because there are a couple of different formulations. Everolimus, which is also the trade name is Afinitor. Some patients here, some of you may have heard about interferons. Probably none of you have received it. It's something that was definitely available in the 80s and 90s and still very rarely used in occasional situations. And everybody's probably with the diagnosis now familiar with PRRT, or the peptide receptor nucleotide therapy, or Lutathera as it's commonly referred to. And I'm going to discuss about clinical trials. Now, I am not going to maybe talk about pancreatic, which is also has a few other options, including capecitabine, temozolomide, and sunitinib. But some of them, some of those questions come up even in the context of small bowel neuroendocrine tumors. When I start looking at a patient, I start looking at these factors first: grade and differentiation of the tumor, the stage of the tumor. Is the patient symptomatic with the tumor? Is it slow volume or multiple areas of involvement? Is the tumor secreting hormones and the patient has symptoms related to it? Is it in the liver, outside the liver? Where else is the cancer present? All these are helpful to make decisions. And also you have to look at the patient themselves to see what is their health overall, what are the other problems that they have. Is it like diabetes? Do they have any kind of heart problems? Do they have what is their quality of life? How is it impaired by the tumors? And access to therapies. Do you have access to a clinical trial? Do you have difficulty getting to one? When everybody talks about grade 1, grade 2, grade 3, it's hard for patients to imagine what it actually means. So here I actually have a slide that shows, I am not able to see my cursor, so I'm not sure if you guys are. So slide A refers to the first slide here shows a grade 1 and grade 2, grade 1 neuroendocrine tumor. On the slide B, which is the second here, actually, I'm going to probably change to this mode so I can actually point my cursor. I'm sorry. So right here is a slide B, which is looking at those tumors when they put a little dye called Ki67. So Ki67 refers to how many cells are dividing, and you barely see these brown dots. So a very, very slow growing tumor under the microscope looks like this, with barely any cells dividing. A grade 2 tumor, which is right here, as you can see on this D section here, has these brown dots. So when they put this dye for the Ki67, these are the cells dividing in this field, so slightly faster growing, and this is a grade 2 when it's less than 20% or 3 to 20%. So this is slide A and slide B I was referring to. This slide B is where the Ki-67 or the stain for the proliferation is put. You barely see those brown marks right here. And here on this D panel, you see the tumor has these brown dots, which is the Ki-67 dye, and you can see more cells are dividing. So this is the difference between a grade 1 and grade 2 tumor, where you have more cells dividing. So when this number is between 3 and 20%, you call it a grade 2 tumor. Now, it's very different when you look at this slide here. I'm sorry, I'm not putting in presentation mode because the screen is freezing for me. So I'm just going to use this and as much as possible, like expand. So here you have the first two panels. You're seeing the brown dye on this end where I have my cursor as multiple brown dots. This is a very fast growing tumor. And on this slide, you can see you don't have a very well assembled tumor like here, what we call a well-differentiated tumor. It's just like pure chaotic appearance. These are small cells, these are large cells. So that's where the small cell carcinoma and the large cell carcinoma comes. And the proliferation rate is here almost like 70 to 80%. So more cells are dividing. And then some of you may be familiar or have heard this term of well-differentiated neuroendocrine tumor grade 3, which is kind of this evolving category, especially in pancreatic, where it's still well-differentiated. You can still see some kind of glands formed here, but then the proliferation rate with this Ki-67 dye, the brown dots you're seeing, is more than 20%. I think if you get a visual sense of this, now it's important to know the tumor is not the same in every spot, and the tumor can also change over time. So this just gives you an idea how we guess what the tumor is going to do based on its activity in a biopsy and why we emphasize on this grade and biopsy at every juncture. So briefly going through the list of options that may have already been covered in the other talks, we look at octreotide and lanreotide as one of the first options. Between the two, a lot of patients ask, which one should I go on? Sometimes it's the insurance that actually dictates your formulary drug. Really, no definitive statement can be made about the selection when you're using it for both symptom control as well as for what we call tumor control. So there was one of the questions in the breakout that was asked, I just have a tumor and one liver metastasis. Should I go on this octreotide therapy, which is often the first therapy? And the answer is not necessary. Typically, when a patient has symptom or functional tumor, usually that's diarrhea or the flushing, or some people have the night sweats or the palpitations from the tumor that makes the hormones, then we institute this octreotide therapy in a way to control the symptoms. Now, if it is asymptomatic, now I want to emphasize that sometimes the serotonin or the other hormones we measure can be elevated. The patients may not have symptoms though, meaning they don't have the diarrhea, the flushing, or other classic symptoms. So that's not quite functional tumor in the terminology we use. In those patients, if it's limited burden of the disease and the cancer itself where it's located is not causing symptoms, observation with close surveillance is also an option. So you don't have to necessarily go on octreotide, and that's at least clinical practice. But if the tumor starts growing with serial scans, then definitely this is one of the first options that's used. Now, the other therapies I refer to, interferons and chemotherapy, we don't usually invoke chemotherapy in these small bowel neuroendocrine tumors, versus in pancreatic neuroendocrine tumors, capecitabine temozolomide, which is often referred to as CAPTEM, is very commonly used. In small bowel tumors, unfortunately, they don't have the same kind of benefit or the response. And then the other often used treatment is the everolimus or Afinitor. And this is just a study that showed included small bowel neuroendocrine tumors as well as lung and unknown origin. This can be a tough drug for many patients. If you look at the side effects of mouth sores, almost half the patients in about had some degree of mouth sores. Definitely 1/3 had diarrhea, fatigue, some infections, and acne like rash. So definitely, most patients have some struggles or some dose adjustments necessary for this. So this is just kind of the landscape of some treatment options. I have not covered liver-directed treatments and surgery, but moving on to some of the questions that were asked in the breakout session. So one of the questions that was asked was about liver toxicity with PRRT. So PRRT refers to the radioactive therapy called Lutathera, where you have a tumor and you have a receptor with octreotide sitting there, and you give lutetium, which is the FDA-approved version of therapy, tacked to the octreotide through IV 4 times, and it goes and sits on the tumor, and the lutetium gets to the tumor and does the DNA damage. So there was initially, when patients got PRRT, they were heavily pre-treated, meaning they had gone through a lot of other things, surgery, embolization, sometimes including radioactive embolizations, there's definitely the concern about how much can your liver handle or what can your liver handle. And then there's a lot of variability. Some patients have like a limited amount of liver involvement by tumor. Some have the liver full of tumor, which is also one of the questions. What is an option for diffuse involvement of the liver? Now, certainly there were concerns and there are ongoing concerns raised, and the data, the literature is very split. So one of the study here that I'm presenting is a group of patients that were heavily predated with liver metastasis predominantly or liver involvement. And if you noticed, a good chunk of those patients had an episode of liver toxicity in when they got PRRT after multiple lines of therapy. Liver toxicity can be buildup of fluid, what's called as ascites, like abdomen swells up with fluid, the liver number elevation, and sometimes bleeding, which can be a problem when your liver is not functioning well. So these are some of the liver toxicity symptoms that can occur. And so definitely they noticed that in heavily treated patients, which beg the question, should you be treating these patients earlier with PRRT? The NETTER-1 study, which is the largest study with PRRT that led to the approval, did do an analysis of looking at the liver tumor burden, how much was tumor in the liver, and they had patients like scored into low tumor burden, where they called it 25% and lesser of the tumor. I have to remind patients also that this is all very subjective categorization because there's no very good measurement tool for how much of your liver is involved. This is almost like in some ways a medical eyeball judgment. Moderate when it's 25 to 50% of your liver and more than 50%. And in NETTER-1, which was carefully selected patients, though, there was no difference in notice when you had high tumor burden, both in terms of toxicity as well in terms of response. So you have kind of differing data for about the liver toxicity and what to do about it. I think out of abundance caution and based on anecdotal experience, a lot of us are much more careful and definitely would say in practice, we are going a little bit away from the radioactive embolization in patients who we are considering PRRT in the future, or being conscious about how much they got before or the interval before they get another type of treatment, just from many of these unknown factors with respect to liver toxicity. Now, this does not address the question that was asked, what about the diffuse liver involvement situation, which is a very hard situation because it is interesting how in neuroendocrine tumor, your liver can be quite significantly involved and the patient may not be symptomatic. They can carry on almost maintaining this balance with the functioning liver and the non-functioning or the tumor burden liver. But then, when you start doing things, you worry that you take away the reserve from this normal liver. We wish we had a great way to calculate and tell patients, 20% of your liver seems to be working well and 80% is tumor. Let's hold on to the 20%. And if I do PRRT, we'll take 10% more out of the liver that's functioning. But unfortunately, there's really no good tool. So certainly in those patients with very high liver burden, which is again a word that's subjective, we are much more careful because when you do many therapies, when you don't need to do it, you could tilt the balance and actually cause some more damage than you want to or hope to. But it's a catch-22 situation because when the tumor grows, you are going to be also in a precarious situation where your liver function could be compromised. So you're always thinking, should I do this? Should I not do this? Because I'm worried if I do something, my liver is already full of tumor, I'm going to make it worse. Then on the other hand, you're thinking, okay, if I don't do anything, my tumor is also going to do the same thing possibly. So it's definitely a very tough situation for patients who have that kind of a liver involvement. So I think that's the best I can address that question that was asked. Moving on to repeat PRRT, that was one of the questions that was asked about repeat PRRT. Is it being done and how many have we done at Iowa or specifically, and what are the things to remember? So there's certainly a lot of data with repeat PRRT and even repeat PRRT. This is actually a data set from Netherlands where they did what we call repeat, and that's RR-PRT. 13 patients were treated with basically 3 times over. And if you look at the benefit or the data, it's all about patient selection. The longer you had with the first round of PRRT, in other words, if it was successful the first time, those were the patients they were treated again with the PRRT. So like in this group of patients, after the initial PRRT, the median PFS was 33 months. So they had a good interval where the cancer was not growing before they went on to get repeat PRRT. So there was patient selection to begin with, or choosing the patients whose tumor is anyway doing better. And again, majority of the times it's stable disease. Of those patients that were repeatedly treated with PRRT after 4 rounds of lutetium, it was mostly stable disease. And if you look at the second time, the success was lesser in the average. So like the first time it lasted longer, the second time it does tend to last longer, at least based on available literature. When I say it lasts lesser, it means like how long is your cancer stable and you don't need another treatment after getting PRRT. And the same thing with this large study where you have almost 13 patients, 168 that got repeat PRRT after the first round, and 13 got repeat PRRT. And as you go along, the interval between the success or before you need something else goes lesser. Toxicity is another concern, and it's hard because when you get numbers that are lesser and lesser, it's hard to make conclusions, but you did notice the bone marrow toxicity went up by 6% compared to the first time you get when it's certainly lesser. Does the leukemia risk go up when you get further in this group? That's the largest group so far reported, was still at 2%. That's the same as you get when you get the first round of PRRT. So it's very hard to conclude when the numbers get smaller. So with that, I mean, so repeat PRRT is certainly an option. There's definitely going to be limitations of success, limitations in the patient selection, and possible toxicity that you have to keep in mind. And I think whether you go with the same lutetium or should you go on to an alpha PRRT, which is the next thing that's coming up, those are also questions that are unanswered, and probably a trial participation would be encouraged. There's also a question that was in the breakout as to why doesn't it work for somebody, or why does it not work? I think that's the biggest question that we're all trying to answer. Why does it not work for everybody? Because we know some patients right after getting PRRT, it doesn't seem to do anything and the cancer keeps growing. A lot of studies and observational studies are being done at this time, and looking at population data as well as blood-based data and tissue data. At this time, I don't think we have very good answer as to why it doesn't work. And also a reminder, in the majority of the patient, PRRT doesn't shrink tumors. It keeps things steady in the majority, and that's your goal because it's a slow-growing tumor. So the goal is many times still stability after your treatment. Another question that was in the breakout session, is there a genetic blood test that should determine the risk of this leukemia post-PRRT? So 2 to 3% patients who get PRRT or the radioactive treatment may be prone to blood disorders or leukemias or blood cancers. Now, we don't know how to identify the patients. So there is an interesting study that came out of Roswell where they looked, and there's a lot of interest in this area, where we are looking at what we call clonal hematopoiesis. So normally we all have stem cells, and stem cells in your blood are supposed to become different kind of blood cells. But with time, as you age, sometimes these stem cells start making the same kind of cells. So we call them clonal cells. They look kind of similar, and that's abnormal. So over 7 years, 10% of the patients may have a group of these population cells, and that's normal. But these have been linked to many other cancers. For example, thyroid cancers, ovarian cancers, and so that's definitely a lot of interest in neuroendocrine tumors. What they found in a very small study, which was only like 6 patients where they had the samples. So another reason for all the participants here to think about contributing your blood to the biobanks or anything that you may have options. So they were able to get serial blood draws on patients who got PRRT. And in that small, very small study, they did notice that the patients with neuroendocrine tumor, even at baseline, seem to have a higher clone of this clonal cells, or higher number, more 50% versus 25% in other cancers. So there's a lot of interest in looking into this clonal hematopoiesis cells. We call them CHIPs, in their link to PRRT, but I think we need a very large global study probably to actually make conclusions as to whether we can predict who is going to get leukemia and avoid those patients from getting PRRT or something. So stay tuned, maybe we'll get some answers in the future. So then there are also questions about what's a safe blood level to begin PRRT. You know, when they treated patients on NETTER2, they actually used a cutoff of less than 75,000 and excluded those patients. So that's kind of what we go in majority of the centers. But I think it's more important to look at the numbers drop as you treat and look at the safety, because sometimes when you're at 3 or 4 cycles, some of you may have experienced the platelet counts. You may have started out a different number, but there's greater than 50% drop from your baseline. And then you may hit a point where you question or discuss with your treating physician, should you proceed with the 4th one? Should you go with a half a dose, or what should you do? So that's a different question than when you start with therapy, because when you treat is when you drop those blood counts. Now, Another interesting question that was in there that I want to address. So I think I covered many of the PRRT questions that were there. The alpha PRRT question, I may jump to alpha PRRT just more as a discussion point. I think a lot of patients are asking about, can I get alpha PRRT? So alpha PRRT refers to, instead of using lutetium, you're using a compound like lead or actinium, the two that have been studied so far, which emit alpha rays. These are heavier molecules that actually tend to get better tumor penetration in mouse data. So certainly a lot of interest. There are going to be clinical trials. There are a couple of trials already open for PRRT naive patients, meaning those have not been treated and looking at PRRT. But there are also studies that are going to be coming up for those who had already received PRRT and the cancer has grown. And in some studies done, they have shown activity even in patients who had received PRRT and were refractory, meaning they did not respond to the initial PRRT. So maybe there is something different about alpha that can get to the tumor that we have to figure out as we do these trials. The last question, because we have 5 minutes, that we have is grade transformation. Some of the questions that were asked about, what percentage of patients do progress from a well-differentiated to a high-grade neuroendocrine tumor? Now, I'm going to actually start with a few CT scans. Actually, I had 2 or 3 patients in this clinic last week that I pulled up some CT scans. So this is a patient who had a pancreatic neuroendocrine tumor. Up here is the scan in March, and this is the scan in July. The patient had surgery, which is the black hole here. But right around this area is the tumor. This is the vena cava, so don't look at this area. In 3 months, this tumor, as you can see, has grown significantly. This is a patient who's had a neuroendocrine tumor almost for 5 years, growing very slowly. And this is a 3-month change, which obviously means something different is going on. And so this is a gallium PET CT and an FDG PET CT, which was done at the same time. Gallium PET CT is the traditional one that you're all used to, but whenever a clinical change like this happens, I tend to get a repeat biopsy, and if possible, an insurance pays for an FDG PET CT. And this is actually very interesting to look, because you are seeing in the gallium PET CT multiple other tumors, which are all showing the octreotide receptors. Here on the sugar PET, as we call it, or FDG PET, you don't see those tumors light up here. But this area that is behaving like a rogue, showing up sugar uptake. So this kind of signals this tumor is growing differently, and certainly behaving like what we call a transformed or higher grade tumor. Another example of another patient with a small bowel neuroendocrine tumor, again, a 3-month interval on a scan. Here, I'm just putting one scan up, one location of the tumor where there's a big difference here in this white area around this is the tumor that is active or viable. Again, this patient had stable disease for almost 4 years after PRRT, and then this sudden change happened. Again, got a gallium PET CT, which is right here, and you'll see many more tumors that are still octreotide receptor positive, but that one focus that was behaving differently, you can see that is clearly showing uptake with the sugar PET. So grade transformation is something that we are recognizing is happening. And another example of gallium PET CT and FD, this is the other way. This is the gallium PET and this is the FDG PET CT. So in a series of about 400 patients, 46 patients had baseline and repeat biopsy. And you can see a good chunk of patients. So this is the line that stayed the same, but a good number of patients, more than 2/3, had a jump in the Ki-67. Now, it doesn't mean 2/3 of the tumors will change the Ki-67. These were biopsies done because there was a clinical change. So what is the actual number or the percentage where this transformation happens is probably unclear. And why it happens is probably a bigger question, but it's important to recognize that it does happen when something is not fitting with the usual course of the cancer. Remember, this happens. Repeat biopsy or repeat scans using the 2 PET scans we talked about may be helpful to figure out your next options. Because those that did have this transformation, the tumor that did jump the grade, unfortunately did not do as well as the others that did not. So we know when a faster growing tumor makes an appearance, the prognosis, meaning the outcomes, the treatment options can all change. So I think I covered most of the questions. There was one question about peritoneal carcinomatosis. Why does it think like it's not as responsive to PRRT? So briefly, this is one study that looked at patients who had peritoneal metastasis. 32 patients were treated with PRRT, and 40% actually there was growth in the peritoneum. And further, a lot of these patients experienced bowel obstructions or ascites, which is like the fluid buildup. So certainly with this is one of the largest case series. We know that area in the belly cavity is just not the same as what's in the liver or other areas. And there's also likely to cause more symptoms to the patient. So this is actually all the reasons to think about peritoneum differently. I think that covers many of the questions that I was asked. And unfortunately, I don't think I could cover any others that came up in the chat. Please feel free to email me or anything else that I can help with our neuroendocrine tumor team here. Thank you so much for this opportunity. It's always a pleasure to talk to everybody, even though this has not been like interactive like I thought, but hopefully next time in person. Thank you.